Welcome to the HealthiHer podcast. Your host, Dr. Amy Brenner, is a board-certified OBGYN with additional certifications in functional and integrative medicine. This podcast is meant to help women find reliable, relevant information to help them feel better, look better, and live better. Here you will hear in-depth information about hormones, sexual medicine, aesthetics, cosmetic gynecology, and functional medicine.
Hey friends, welcome back to another episode of HealthiHer. And we've been doing this now for quite a while, and we have yet to talk about one of the most common surgeries in the United States, and that is hysterectomies. So we have a really qualified guest today, all the way from California, and her name is Dr. Cheruba Prabakar. So welcome, Dr. Prabakar. Before we get into it, everybody loves to know who we're talking, and I know you have a lot of credentials to be our expert in hysterectomy. If you can tell everybody about your background and education and kind of what your approach is to medicine and how did this become your area of interest?
Yeah, sure. I would love to. So I'm from the East Coast originally. I went to Smith College in Massachusetts and then went to med school at University of Connecticut. And during med school, I really fell in love with OBGYN during my rotations because of the diversity of what I saw every day and just the scope of practice in this specialty. And I did my residency in New York, in Long Island. And after that, there was a lot to learn in residency with OBGYN. There's the delivering the babies part, and there's a surgical aspect, and even within surgery, there was just so much to learn. There was laparoscopy, vaginal surgery, robotic surgery, open surgery. So I felt like I really, to be really, really proficient, I wanted to spend a couple more years doing a fellowship in just minimally invasive surgery. And I was very lucky to find a spot in Brooklyn, New York. And so I did a 2-year fellowship in minimally invasive surgery, and then I married a guy from the West Coast in tech, and so moved all the way out here to the Bay Area. And I wanted to find a place that was, kind of as diverse as Brooklyn. And so we settled in Oakland, California, and so that's where I am right now.
Yeah, for those who don't know about it, what does minimally invasive gynecology mean? So what kind of stuff were you learning in your fellowship?
Yeah, so minimally invasive means doing surgery with less incisions. So traditionally, when women have had GYN surgery or really any surgery, we're talking about big incisions in the abdomen. So either like a C-section incision or sometimes even an up and down incision from the belly button to the pubic bone. So we're talking about big open incisions and big surgeries. But over time, we're able to still accomplish those surgeries with very tiny incisions. So now we're talking about 2 to 3 small 5-millimeter incisions and putting instruments through those incisions and operating. So it's really great because, your incisions are tiny and most patients get to go home the same day and recovery is much faster.
Right. So we're going to talk about hysterectomy. Just in general, what does the word hysterectomy mean?
Yeah, so hysterectomy is the word to describe removal of the uterus. And that's what this procedure is about. And while I say that, I also want to say it does not mean removing the ovaries. There's a lot of confusion about that word hysterectomy and that procedure name. Women often think it means uterus plus ovaries, but it's not. It's just removal of the uterus.
Right. That is actually one of my pet peeves of even just working with my staff in my office. She had a complete hysterectomy. And like, that's not really a word. Patients use that word, but that's not really a medical word.
Exactly. I think there's a lot of confusion about that. And I think even doctors have used that in the past. And so it's just gotten passed around. And so, yes, hysterectomy versus, total hysterectomy is the cervix plus the uterus. And then the ovaries are a completely different, surgery. And so I try to stress that to patients that a hysterectomy does not mean you're going to enter menopause and your hormones are all going to change. So that's a very important point because patients are often scared about that. As soon as you mention the word hysterectomy, they think, all their hormones are going to go away. And, that's not true.
Right. What are some of the most common reasons why women would need a hysterectomy or seek to get a hysterectomy?
The most common reason I would say is heavy bleeding. And this is most often caused by fibroids. This is one of the biggest reasons women seek hysterectomy. Without fibroids, if you have other causes of bleeding, they're often controllable with, medications and other simple procedures. But when a woman has large fibroids that really affect her quality of life, that's when a lot of women are seeking hysterectomy.
Yeah.
And that's true in my practice.
Same. Because otherwise, unless you have big fibroids, there's, like you mentioned, sometimes you can use medications or other minimally invasive outpatient procedures to deal with the cause of the bleeding. You mentioned now when I was a resident, we basically did two hysterectomies two ways. We either cut you open with a big, like a bikini cut or a C-section scar, or we did it vaginally. Now there's several different ways to do a hysterectomy. Can you comment on the different routes or different ways to do a hysterectomy?
Yes. So as you said, we still sometimes do the big open incisions, but that is very rare now.
How many are you doing a year of open hysterectomies?
Probably 4 or 4 or 5 or something like that. Yeah, pretty rare.
Pretty rare.
Pretty rare. But sometimes when women have huge fibroids and based on their anatomy and stuff, it is necessary, but rare. The vaginal hysterectomy, interesting that you mentioned that. I think that is still one of the best routes. But in my practice with women with large fibroids, often that is not a feasible route because these fibroids are not going to fit through the vagina. We still do vaginal surgery for women with prolapse, where the uterus is essentially, falling out. So I still do vaginal surgery for that. The other two that have really taken off in the last couple of decades have been the laparoscopic surgery as well as robotic surgery. And essentially, these are approaches where we're using very small incisions, anywhere from 2 to 5 small 5 millimeter incisions to put in instruments and operate that way. And laparoscopic and robotic surgery are very similar. The robotic platform, however, offers some 3D visualization, removes tremor, and you can sort of see better, suture more easily, versus the laparoscopic is 2-dimensional and you don't have some of these additional features. But the idea is the same in that you have a few small incisions, you're able to go home the same day, you're able to walk around and move around a lot faster and get back to your life quicker.
Yeah. For the longest time, this was, I don't know, maybe over a decade ago, I was doing surgeries laparoscopically and thought, I don't need the robot. Like, I can do it laparoscopically. And then one time I just peeked in on a colleague doing a complex dissection with endometriosis and thought, you know what? I probably couldn't do that laparoscopically. And so then I said, you know what? I'm going to learn robotic surgery. And now I'm 53 and I am just so grateful that I did, because doing laparoscopy, it's like a workout. Like my arms would be hurting, my back would be hurting at the end of the day, versus as a surgeon doing robotic surgery, you're sitting and it's just not as strenuous physically.
Yeah, I totally agree. When I did fellowship, my attending was like, okay, do laparoscopy as much as possible. And then we did our fibroid surgeries robotically, but we tried to do as much laparoscopically as well, because he really wanted us to be trained with both. So when I came out for the first several years, I was very into, doing laparoscopy mostly. But then I agree with you. I think like you, I was like, oh, well, this is great. I can sit for 3 hours. I can see a lot better. I can suture faster. And so I've also slowly, converted a little bit more into the robotic approach.
Right. So I don't know if you were in practice then, but there was a time, again, this was probably 15 years ago, where there was a trend to not remove the cervix. It doesn't come up as, and so for a while I was doing what was called a supracervical hysterectomy, of removing the uterus but leaving the cervix. Did you ever go through a phase where that was popular in your career?
Yeah, that's a good question. And, I actually find that it's a little more regional. So I did my fellowship in New York, and that was definitely a thing in New York. And that was only 7 years ago, where women did not want their cervix removed. So we did a lot of supracervical hysterectomies when I was in fellowship. And then I came out to California, and almost no one did supracervical hysterectomies here. It was all total hysterectomies where women removed their cervix as well. And so for me, it was very interesting. It was a very geographically, it was a geographic difference there. And now I think I would have to say I mostly do total hysterectomies. I give women the option, and, they just don't want to have the risk of any abnormal paps in the future and or cervical cancer, and they just opt to remove their cervix as well.
Same.
Mostly.
I found people were very frustrated, is because if you left the cervix, maybe 10-20% would still have a little bit of spotting, and they were like, wait, I went through this surgery and I still have a little bit of spotting every month. This is really annoying.
Right, exactly. That's definitely one of the risks of leaving your cervix in. And we tell patients that. Some patients are also, they've kind of come to this decision of hysterectomy after a long time, and they really want to remove as little as possible. And so then they end up leaving their cervix. So I think it really depends per patient. But yeah, it's a conversation.
What do you tell people? A common question we get is, well, I might have read that, what is sex going to be like after a hysterectomy, and what is sex going to be like if I remove my cervix?
Yeah, so there have been studies that have looked at this exact question, and they have found that there's really no difference with satisfaction with sexual activity, with removing your cervix. And I'll say anecdotally, like for my patients here, most of my patients here, and over the last 7 years, I've done total hysterectomies, and really no one has complained that the sex life has been worse. If anything, people have said it's been better. So
Correct.
There you go.
Yeah. Anecdotally, I don't ever remember somebody telling me like I had a hysterectomy and now sex is different. So yeah, as well as there isn't any erectile tissue in the cervix. So scientifically, it doesn't make sense that why would that affect arousal or orgasm?
Yeah, that's correct. I think there's just a lot of misinformation out on Dr. Google and the internet, and I think women just read that and get concerned. And like I said, I think some women really have had a hard time admitting or coming to the conclusion of like, okay, like I really need a hysterectomy now. And those are the women who really want to remove as little as possible. So they just want to take care of the uterus and the fibroids, and they want to leave whatever doesn't need to be touched. So
yeah.
Yeah.
Let's talk about what the recovery is like, because sometimes my experience has been is, nowadays you mentioned most people go home, and that's been my experience as well. People go home the same day. You have these tiny little incisions. And so from a surface view, you might think like, oh, this is like in and out surgery, no big deal, but it still is major surgeries. So what do you tell people of what to expect as far as recovery from hysterectomy?
Yes, so that can be definitely misleading. As you said, people think, oh, yeah, I'm going home the same day. And, I've got patients who tell me, oh, okay, I'm returning to work next week. And I'm like, okay, no, not yet. Because, we still did take out your uterus. And especially if we took out the cervix as well, that is, adds on a couple of weeks for recovery. So I tell patients that, it's great that they're going home that day and they should expect to, walk around and start moving around that night or the very next day. They want to do that to prevent blood clots as well. So walking around the block and starting to move a little bit is good, but they should expect to still feel very tired. A lot of patients say just going through surgery, even though their pain is minimal, they feel extremely fatigued and they have to, rest or sleep a lot. Also, with a total hysterectomy, often, patients are spotting or bleeding. The vaginal cuff that we sutured is healing. And the vaginal cuff is the area right between that cervix and the vaginal wall that we are suturing after removal of the cervix. So that takes a little while to heal. Actually 8 weeks. And so I tell patients no sexual activity for 8 weeks. So overall, to really return to work and go back to, if you're now, of course, after the pandemic, a lot of patients are working from home. But for those who actually have to physically go into work and be active, I tell them, hey, it's going to take, 7 to 8 weeks. And for those who are working from home, maybe on their computer, I say, okay, see how you feel, but it may take about, 3 weeks before you're even mentally all there to work a full day.
Yeah, I couldn't agree more. So I agree. I usually tell people it's going to take about 6 to 8 weeks before you feel back to normal, but most people are going back to work at the 2 or 3 week mark. Some people sooner, some people later. Everybody's a little different.
Right, right. But, for example, if we had a hysterectomy, where we're physically in the hospital and running around and seeing patients and operating and stuff, I tell those patients, okay, it is going to take you the full 8 weeks because you're lifting and, you want to be careful. So
what are some of the risks of surgery? Is for you and I, this is something we do very frequently, but it does have risks that I'm sure you and I both discuss with our patients.
Yes. So the risks that I describe to patients, first of all, with any surgery, there is a risk of infection and bleeding. So that can be treated with antibiotics. If you're bleeding a lot, you may need a blood transfusion, and this is rare. But those are 2 risks definitely that come with any surgery. And then for hysterectomy specifically, there can be injury to other organs that are nearby the uterus, like the intestines, the bowels, any blood vessels near there, the bladder, which is right in front of the uterus, and the ureters, which are the 2 little thin pipes that carry urine from the kidneys into the bladder. And so all of these are very, very close to the uterus and the cervix. And for patients who are undergoing a total hysterectomy or, removal of the cervix, the risk of kind of the injury to the ureter and the bladder are a little bit more compared to patients who are leaving their cervix in. So I go over that as well. These are about, 1 to 5%. So those are the risk, kind of the statistics that I quote. And luckily, they're very rare, but they can happen. And we take care to, notice them, obviously, if it does, so we can fix it while the patient is already under anesthesia. And so that's sort of the discussion I have.
Yeah. It's not very often that I tell somebody, despite possibly that hysterectomy is going to help them, it's not very often that I tell somebody, you're just not healthy enough to have a hysterectomy. In fact, I actually just had to tell somebody that recently, which is it's a hard conversation to have. But what are some of the things that you're looking for of, are you healthy enough to have this surgery? Or have you even encountered that? It had been, I don't remember the last time I told somebody I know this is what you want, but I think you have a high risk of death of having this. Let's look at other options for you.
Yes, I think I've had a couple of patients in the last 2 years, and one was a patient who had very, very bad endometriosis, and somebody had operated on her before for like an ovarian cyst, and had described in the operative report that it was just very complicated. There was just scar tissue everywhere, and the patient was pretty close to menopause anyway. So that was a patient that I said, okay, we could do it, but this was a perfect example where probably the risks outweighed the benefits. If there was an injury to her bladder or her bowel, she was really in a worse off shape than having than not having the hysterectomy. And so that's one patient. And the other patient had a lot of medical conditions that would require very high level like ICU care if they flared up. And so that was a patient that I said, okay, maybe you want to try one of the alternatives. And if you do absolutely want a hysterectomy, you have to be at a tier 3, like big academic center where they had all the specialists on hand and, quick access to the ICU as well. So, but you're right, it's rare. It's rare. Yes. And most women in their 40s and 50s, or even late 30s who are looking for a hysterectomy are overall fairly healthy.
Yes. But those definitely are things that are important when a surgeon is assessing, like, how are you going to do post-op? Do you have diabetes? Do you have high blood pressure? What is your weight? If you do have those, is your blood pressure or diabetes under control? Like you mentioned, what your other surgeries are. So there's a lot of things we have to think about when we're
there's a lot to think about. And also obesity is the other big one. Now when patients are morbidly obese, I do suggest bariatric surgery before they contemplate a hysterectomy, because then we've got complications like dehiscence, or where when we close up the incision that it actually comes apart, and even with minimally invasive surgery like robotic surgery, that belly button incision can, we often have to make it a little bit bigger to take out specimens, and that can kind of come apart after, a week or so if a patient is really, really obese. That's actually happened to me. And so I usually suggest that if a patient really if they're contemplating a hysterectomy in the next year and they're morbidly obese, I say, okay, this is a good time to bring down that weight, seek bariatric surgery if you need to. So that's another complication.
Yeah.
And with the diabetes and blood pressure, as you mentioned, even if I do a robotic surgery, if it's really badly controlled, those are patients I may say, hey, better for you to stay overnight, one night, until we get everything, even keeled, make sure it's all good before you go home.
Right. What about long-term consequences of hysterectomy? Like, okay, everything went fine with surgery. There was no infection. There was no damage to other organs. There was no blood clots in the legs or lungs. But what about a year down the road, 5 years down the road? Anything somebody needs to be aware of that might change their health risk in the future because they've had a hysterectomy?
One thing I do mention to patients is the slight risk of prolapse with a total hysterectomy if the cuff isn't suspended. And what I mean by that is when we take out the cervix, we're really dissecting all the way down below and cutting into some of the support structures of the vaginal wall overall. And so over time, this can start to sag a little bit. And whether you do a hysterectomy or not, for a lot of women, this happens anyway. So this may not be a direct, consequence of a hysterectomy, but for some women, it happens a little bit faster after a hysterectomy. So something just to keep in mind. And there are other ways we can take care of that. But that's really the only additional thing that I've seen.
Another common question I get is this going to affect when I go through menopause? Or along those same lines, how will I know when I do go through menopause?
Yeah. So, I mean, when you do a hysterectomy, you're not going to get a period again. So for a lot of women, that's how they know they went through menopause, is because they stop their period. So you won't be able to use your period as a marker, but you still have your ovaries. And so you're still going to be getting the estrogen. And I tell women you're still going to often experience like PMS type symptoms. You just won't have the bleeding. A lot of women can tell still when they undergo menopause because they're having the hot flashes and the sweats and the mood changes. So they're usually able to tell even without their uterus.
Right. Well, I think this about covers it. I know that there are so many factors to consider when somebody's thinking about hysterectomy, but I hope this information has been helpful and has given patients or anybody listen to this some good insight into the pros and cons of having a hysterectomy should you ever need one. So where can we find you, Dr. Prabakar?
Yeah, so you can find me on YouTube at The Fibroid Doc. You can also find me on Instagram with the same handle, The Fibroid Doc, or you can check out my website at www.drprabakar.com.
Thanks so much for joining us today.
Yeah, thank you so much for having me. This was great.
Thank you for listening to this episode of HealthiHer. You can find us on Instagram, Facebook, and the web. Go to www.dramybrenner.com to learn more. This podcast is for general information only and does not constitute as medical advice, the practice of medicine, nursing, or other healthcare services. No patient-physician relationship is formed. The information in the podcast and any references, material, or links are at the sole discretion of the listener and not meant to be a substitute for professional medical advice, diagnosis, or treatment. Listeners should not delay or disregard obtaining medical advice for any medical issues or diagnoses that they may have, and should seek medical advice from their healthcare provider for any such conditions.